Hello, good afternoon, everybody. Thank you so much for joining us today. This is our third webinar in this series of COVID-19. As all of you know, that there have been a lot of changes that have been happening since we've had, since the public health emergency was declared for COVID-19, and the healthcare industry, the insurance industry, Medicare, everyone's been so busy trying to update these regulations, and there's a lot of stuff to go through. Whereas Medicare has made some changes and they continue to do so, all the commercial insurance companies are also making changes as well. They're trying to follow Medicare. They're trying to do some things to make it easier for the providers and for the members, but each one of them has individual power because each one is an individual company. They're for profit and they make their own rules. So it's kind of hard to keep up with each one of them separately. So what we try to do here in this webinar is we try to get some top payers and bring you some information where everything is consolidated in one place. So hopefully this will make things a little bit more clearer to you, a little bit more easier by the end of this webinar. So let's get started. Oops, okay. How do I go forward here? Okay, here we go. All right, so if you were on my previous webinars, we did the first one on March 26th for Medicare changes, and then we did another one on April 3rd. The April 3rd one was not a live webinar, it was a recording. And at the end of the session today, I'll share with you where those recordings are and where you can access them as well. So I'm gonna just introduce myself a little bit. I did that in my previous two. So if you already know who I am and everything, it's gonna be, I'm gonna keep it very brief. And then we have, so what we're gonna do is we're going to be looking at United Healthcare's policies, Blue Cross Blue Shield of Texas. Since we are based in Texas, we are going to be talking about Texas. Cigna, Aetna, and Humana. So these are some of the bigger payers that you guys have. So if you're taking insurance from patients, so most likely these are your top 5 payers, and these are the payers that we're going to be looking at. And then we're going to have a brief Q&A session at the end of this if it's required. Okay. I also wanted to put out a disclaimer that the information that's being provided in today's webinar has been gathered from various sources such as CMS and insurance payer sites. We have tried our best to get the most relevant and updated information available at the time of this webinar. As I said earlier, things are changing on a dime. It's you know, they may be making some changes as we're doing this right now. So just be vigilant and check your payer sites and you know, for your specialty and for your states regularly to make sure that they are you are getting in on that updated information, and also by verifying patient eligibility and benefits before providing any service for payment from patient. So this is very important. As with Medicare, these are the blanket rules and regulations, but with commercial insurance companies, it also boils down to what plan the patient has. You know, if the patient actually has these benefits. As far as, you know, for the purpose of this webinar and whatever they have posted on their sites, you know, it does show that they are covering most of their plans, but still it's as a medical practice, as a healthcare provider, it is on you to do your due diligence to make sure that you are crossing all the T's and dotting all the I's and making sure that, you know, your patients that you are seeing are eligible for these benefits before you are providing this service. So you're not providing the service and then, you know, you're not getting paid and you're, you know, fighting with insurance companies to get paid. So a little bit about me. My name is Rosemary Bobbitt. I own CodeRight Healthcare Consulting. I am a certified coder and auditor. I have my CPC from AAPC, and I have a CCSP from AHIMA, and I also have an auditing certification from AAPC. I've been in the industry for about 15 years. I started, you know, from front desk in a medical practice. I did billing. I did posting, anything that in the billing department. I've been also a practice manager. I've also done some chart reviews for HCC risk adjustment coding. So I'm familiar with that as well. And then in 2015, I decided to go into business for myself. We are a medical billing, coding, and compliance company. We have several clients that we work with, basically mostly single practice, solo practice practitioners, or small group practices, mostly in the outpatient and practice in the practice setting. And we're based in Allen, Texas. We have certified coders that work in our company, and we provide the highest client satisfaction. You can check out our Google reviews and check out our website to see what kinds of things that our clients are saying about us. And also, so we do medical billing for all specialties, and we also do compliance training, risk assessment for medical practices to get them up to date on compliance issues for HIPAA, OSHA. We do policies and procedure manuals, and risk assessment, as I said, and coding training and all of that. So pretty much anything and everything that has to do with non-clinical administrative side of a medical practice. Okay, so we're just gonna jump right into it, and we're going to start with United Healthcare. So the cost sharing for United Healthcare, they are waiving member cost sharing for treatment of COVID-19 until May 31st for across all of these plans. It's so Medicare Advantage plans, Medicaid, individual and group market fully insured health plans. So this is if you are covered through your employer, these services are applicable to you. But there's also a statement by United Healthcare on their website that says that if you are a self-funded insured through their plan, then they can work with you on an individual basis. It doesn't say that they will waive your cost share for that. So if you have patients who are like self-employed, who are covered, through their own with their own money, there's no employer paying for their insurance, this may not be applicable to them. But of course, do your due diligence, make sure that you are following up with the insurance company and making sure that these services and these cost sharing waivers are applicable to them. But this is for the COVID-19 test. So anybody that comes in for if it's suspected of exposure, or has actual exposure, or getting treatment or any kind of diagnosis for COVID-19, this is for them. And then a patient receives a treatment or for the diagnosis between 2/4 and 5/31. So this is effective February 4th of 2020, and the end date is there as May 31st, but I have a feeling that this date may get extended for sure, because we have no idea when this is going to end, and there are still people who are getting tested. There's still people who are needing these services. So I'm fairly positive that these services will get extended. For all the services that are related to COVID-19 diagnosis and treatment, office visits, urgent care visits, emergency department, hospital stays, skilled nursing facilities. And this also includes in-network and out-of-network providers. So on the next slide, you will see that there's cost sharing waived for other treatments, but it's only applicable for in-network providers. But if this is specifically for treatment and diagnosis of COVID-19, then this they will also pay out-of-network providers as well. Okay, so this is an updated telehealth guidance from United Healthcare. It was updated on April 8th. So you can see that these changes are very, very recent. I saw something this morning. I was kind of doing some more updates this morning, and somebody asked on a forum that they saw something in March, and another person replied in a comment saying, whatever you've heard or seen in March is outdated, throw it out. So, and he couldn't be more right, because yes, anything that was announced in March has been revised and modified and changed several times over. So coming to telehealth services, of course, all the insurance companies across the board are saying to use telehealth and telemedicine as the first line of defense. So patients should be encouraged to use telemedicine services. They should not be putting things off, for their for whatever they're feeling. If your provider can provide this telemedicine service, this will help their patients out tremendously. It'll keep them out of the emergency rooms in the hospitals, and it will, keep the doctor's office running and keep the lights on, so to speak. So the cost sharing waiver is effective between March 31st until June 18th. So notice the dates, there are different dates, okay? So when we looked at the previous slide, it was for COVID-19 diagnosis and treatment, and it was applicable between February 4th through May 31st. But these waivers is for anything and everything. This doesn't have to be COVID related. It can be non-COVID as well. So this is effective March 31st through June 18th. So let's say you submitted claims you started seeing patients via telemedicine March 18th. That's when most of the regulations came out. So you started seeing patients on March 18th, and you submitted claims from March 18th, and United Healthcare paid, but then they're saying that patient has a copay or coinsurance or deductible, which is correct, because at that time the cost sharing waiver was not in place. So any date of service or any claims that are for date of service March 31st and later, the cost sharing waiver is in effect for that. So I have actually seen some claims getting paid, and I have seen that the provider is getting all of the share, and there's nothing that is patient's responsibility. So this is applicable to in-network only. In the previous slide, as I mentioned, that it's anything COVID related is applicable for in and out of network. Here, the cost sharing is only applicable for in-network providers. So if you are an out-of-network provider for a new patient that wanted to see somebody for telemedicine and you're not in network with them, they will be responsible for out-of-pocket. All of these services are allowed: medical, outpatient, behavioral, and physical, occupational, and speech therapy services. All of these providers can provide telemedicine services. Use audio video technologies such as FaceTime, Zoom, Facebook Messenger, video chat, Google Hangouts video, and Skype. So notice it's Facebook Messenger video chat and not Facebook Live. Facebook Live, Snapchat, all those are they're called front-facing public platforms. So when you are on like Facebook Live, anybody else can see it, right? So Facebook Live does not qualify, but Facebook Messenger does, because it's a one-on-one chat between the provider and the patient. So all of these platforms are applicable. Zoom, I know, is being used extensively. It's got a good interface where you can share the screen with the patient and share their exams and their results and stuff. So Zoom has been working great for some of our clients, as we have seen. Services may be COVID-19 or non-COVID-19. So this could be anything and everything, cough or headache, or anything that has to do with behavior health as well. So this next one that I have here is that audio only is allowed with place of service 11 for office visits. Okay, so this is something that is new. Okay, Medicare still does not allow audio only for an office visit. But as I was reading through some of these payer sites, as I was doing my research, a lot of them are allowing audio only. So this is something that probably needs to be verified, because as is stated on their websites, they're saying audio only is allowed. But I would be a little bit leery about that, because as a healthcare consultant, I would think that you cannot diagnose a patient or have a complete sense of what the patient's going through just by listening to them on the phone. I mean, the office visit has to be duplicated as much as possible as the patient was in the office. So I would, even though this is in place, and if the patient really needs it and they're technologically challenged and they cannot be on a video and audio platform, then I think this is good. But I would probably use this with a lot of discretion, even though it's allowed. Just because it's allowed doesn't mean you should just do it. But if it's necessary for your practice, if it's necessary for your patient demographic, because they're elderly people and they don't have phones with cameras, or they cannot access computers with cameras, then this is another avenue. Just remember, Medicare still does not allow audio only for 11 place of service for the office visit codes. You have to use the telephone codes for Medicare. The CPT codes that are allowed is 99201 and 99215, modifier 95. United Healthcare, if you are a specialist, United Healthcare does not allow consultation codes. They have let that go last year in June. So since June of 2019, they do not allow consult codes. So if you are a specialist and you're seeing a new patient, even though they're referred by somebody else, they're referred by another primary care physician or another physician, you cannot use a consult code because that United Healthcare does not recognize consult codes. Modifier 95, as I said, and of course, verify benefits to ensure patient has telehealth benefits. So this is very important. This should not be taken as a blanket rule. And this statement is there on every insurance payer site, that they're saying according to patient's plan. So I cannot stress this enough, that make sure that even though all this is being communicated to you right here and it's on their website, they still have the discretion to deny your claims because you didn't follow everything the way they wanted. Because these insurance companies don't have to follow certain rules. They make their own rules, like I said. So make sure that you are really doing your due diligence for that. I have provided a link down here for all the scenarios. So United Healthcare actually has some scenarios in here that AMA did last time. So the scenarios will be in there, and they'll take you through what if a patient is COVID, what if a patient is non-COVID, what if the patient comes in for an office. So all kinds of scenarios. It's pretty cool. It's a pretty cool graphic that you can go through. And of course, you can access this this recording later, and I will upload it on our YouTube channel, so you can get that from there, and I'll share more details about that later. One more thing before I move on, if you have any questions, you can type it in. I'm not going to be looking at those questions right now, but we will definitely address them at the end if we have enough time. If not, then you will certainly be able to email me, and I will take care of that from there. Okay, so United Healthcare does allow virtual check-ins, and virtual check-ins are available for new and established patients. And just to backtrack a little bit, even telehealth is allowed for new and established patients. So it's you don't have to have a prior relationship with the patient to allow these services. So what these are, virtual check-ins are that you have to have a you should not have seen the patient in the past 7 days, and it does not lead to an office appointment in the next 24 hours. There was a HCPCS code that even Medicare put out there. It's G2012. This is a live communication that you're having with the patient over the telephone, and it was paying about $14.31. There's another code that's G2010, which is a remote evaluation of images. So if a patient is sending something to they had labs done and they're sending it to the physician, and the physician is looking at those records, he or she can bill G2010 for that patient, and that pays about $11.87. So just want to tell you that the amounts that I have here, these are Medicare rates. United Healthcare may be a little bit more, a little bit higher, commercial insurances, but I was not able to get specific rates for them because they're not publicized. They're actually just in the payer contracts. So I didn't want to get into one of my payer contracts and give you that information because I'm not supposed to. So this is public information by Medicare. So I just put the Medicare rates on there. So they may differ for commercial insurances. So on March 18th, telephone evaluations also, since March 18th, telephone evaluations are also available. So like I said before, that United Healthcare is allowing you to do a telephone evaluation and bill it as an office visit. But I would be leery of that because you're still not seeing the patient. You're still kind of just taking their word for whatever they're saying instead of actually seeing the patient live in front of you. I think that 99441 through 99443, these telephone codes are actually more relevant if you are talking to the patient on on the phone. And these are also Medicare rates that I have listed for 5 to 10 minutes, 11 to 20 minutes, or 21 to 30 minutes. So you can kind of get an idea that commercial payers may be a little bit higher, or maybe not. They may be the same. So that'll only be revealed once these claims start getting paid and we're getting the EOBs with the payments and explanations. Okay, moving on. Oh, we're still on United Healthcare. There was a lot of information on United Healthcare, so I wanted to make sure that I put everything in here. So e-visits, everybody knows that the e-visits are these are for established patients only. And like I said, even so the virtual check-ins are for new and established patients, but e-visits are only for established patients. This is a non-face-to-face patient-initiated communication without going to the doctor's office by using online portals. So, I mean, I'm thinking that if you have elderly patients or whatever, you're probably not using these online portals. But if you are general medicine, pediatrics, if your demographic is pretty tech savvy or whatever, they can communicate through the portal. So they don't need to come in. And these codes can be used for this purpose for your e-visits. You can bill, and these are timed, so you can accumulate the time and bill over 7 days, but one code per 7-day period. Use appropriate place of service 11, 20, 22, 23, so based on where your patient is. And then there's no modifier required for this one. Okay, so I wanted to kind of bring in some prior authorization stuff because I was getting a lot of inquiries from my clients and from other people out there that what are the prior authorization requirements. So a lot of prior authorization requirements have changed for durable medical equipment delivery. So there is no prior authorization required for durable medical equipment. There's no prior authorization required for oxygen but these are for patients that are diagnosed with COVID-19 or they're being treated for COVID-19. So no prior authorization required for durable medical equipment for them. So this is a 3-month period that they're allowing it for, and after the 3-month period, a prior authorization will be required. I just wanted to let you know I don't deal with durable medical equipment. I don't. We don't bill for them, but I was just addressing some queries that I had, so I wanted to put this in here in this webinar, so people who do deal with this may have this information handy. Okay, next. So reduced prior authorization requirement and updated. This was updated on April 10th. Suspending review for site of service for surgical codes. And the way I read this is it means that whatever, if you're like let's say you're a surgery office, right, and you are requesting a prior authorization for surgery for a patient. They're not going to be reviewing clinicals to provide you with an authorization. So that's what I got from this. This was very, very vague, but I do have a link in here that has all the surgery codes listed in here. It has like, small, shaving off a laceration to big things, like a hernia repair or gallbladder surgery. So it has all the codes in there for you. Diagnostic radiology imaging, no prior authorization is required for diagnostic radiology of the chest for COVID-19 patients. So if you are submitting chest x-ray codes for a suspected diagnosis code for a COVID patient, there's no prior authorization required, but all other chest CTs, prior authorization is required. So if there's no, if you're not diagnosing a patient of being exposed to COVID-19 or having COVID-19, and they are having, cough, or they're having some issues that chest CTs or X-rays are required, then prior authorization will be required for those. Okay, so we're done with United Healthcare. We're moving on to Blue Cross Blue Shield, and I promise that the rest of these are not as comprehensive as United Healthcare was. There was a lot of information for that. It will be just 2 or 3 slides each, and I'll just kind of breeze through it because a lot of this information kind of overlaps. So I don't want to, spend too much time on that. So this Blue Cross Blue Shield document was updated on April 8th. So COVID-19 testing to no prior authorization needed, no member co-pays or deductibles when using in-network providers. So for COVID, this is for COVID-19, and see, this is a difference, right? Because when we talked about United Healthcare for COVID-19, any kind of diagnosis or treatment for COVID-19, United Healthcare is saying in-network or out-of-network, either one's fine. But for Blue Cross Blue Shield, they're saying only in-network providers. So of course, you want to verify that information for sure. So the COVID-19 tests that we are talking about, the U0002, which was the HCPCS code that was released by CMS, and then AMA came out with the actual CPT code for the lab test for COVID-19, 87635, and the reimbursement by Blue Cross is at about $51.33. But this is what they're paying to the lab, because the doctor's office is not running this test. The doctor's office is asking the lab to do it. But you can, if you are swabbing the patient, you can bill the specimen handling fee, I believe, or you can bill the nurse visit. I don't think that specimen handling fee actually is getting paid, but nurse visit could get paid. At this time, everything is up in the air. Really, I wish I could tell you that this is paying or that's paying, or this is covered or not covered. I'm just giving you the information that's available as of today. Once the claims start getting paid, once you guys are getting any reimbursements, then the picture will get a little bit clearer. I would love to hear from you guys at the end of the webinar if you are getting these payments, if you are getting the reimbursements, if you're seeing this money coming in. I would love to hear from you and share that information with us if you will. So telehealth coverage, this was actually covered in my April 3rd recording that I did. So for the effective date is March 10th of 2020. Two-way live interactive telephone or digital video consultation. So even Blue Cross is saying that they will do the two-way interactive telephone call, and they will pay that as an office visit. But I would always take caution to that. No member cost sharing for in-network providers. So they're putting their eligibility date for this as March 10th, and I believe for United Healthcare it was March 31st. A lot of dates to remember, and I so wish that all of these companies would just talk to each other and come up with a seamless process where all the dates are same, because I think this is kind of a nightmare for you and us, to put this stuff in the practice management system and our EMRs and remember these dates. So I wish that these people would kind of talk to each other and say, hey, let's come together and make this easier for our providers. But of course they don't want to do that. Insurance companies never want to do that, right? We know that. So place of service 11 per office. So place of service remains as it would be for any place of service. So if you're seeing the patient as an inpatient, it's 21. If you're seeing them in the ED, it's 23, so on and so forth. Modifier 95 is required. So Modifier 95 required for United Healthcare, Modifier 95 required for Blue Cross Blue Shield. And I've linked the document for Blue Cross, and they actually have all the codes in there. They have all the office codes. They have all the behavioral health codes in there as well, that you can bill for via telemedicine. Okay, I'm gonna just take a sip of water here. Just give me 1 second. All right, moving on. So, so prior authorization process. So Blue Cross and Blue Shield will no longer require post-acute care facility to wait for prior authorization to transfer members from an inpatient to an in-network medically appropriate post-acute site of care, such as long-term acute care hospitals, skilled nursing facilities, rehabilitation facilities, and inpatient hospice. So there is no prior authorization required, but they still want to be notified the next business day. So even though they're not asking for you to get a prior authorization, they still want to be notified so they can keep track of the health of the patient that way. If the transfer is for a behavioral health facility, it will require prior authorization. So behavioral health people, please take note of that. And this is in effect until April 30th, and I'm pretty sure this is going to be extended as well. It should, I'm thinking. Extending prior authorization on previously approved elective surgeries, procedures, and therapies. So they're saying that if they have approved, if a patient was scheduled for a surgery between January 1st and April 1st, and you have already taken prior authorization for them, but you had to cancel that surgery or because of a hold on elective surgeries by state governments, then that authorization is actually valid until December 31st. So you will have another prioritization surgery, but you would have to do that surgery before December 31st. It has to be used in a year. It has to be used in 2020. It cannot be overlapped. It cannot be carried over to the next. All right, so it was painless. Only 2 slides for United Healthcare. Cigna. Cigna updated their policies on they are also waiving cost sharing related to COVID-19 screening, test, and treatment through mixed. So this is across. So all insurance companies are come together in that sense where if anybody is diagnosed with COVID-19 or seek treatment for COVID-19, all the cost sharing is with. That's very good. All these insurance companies are doing that and are on board with it. Them is date of service March 2nd until May 31st. This is again a different day range. So every pair has their own day range into that. The date may get extended, it may not. We'll just have to wait and see because they are updating this stuff almost on a regular basis. The POS places that would typically build if the service was delivered face-to-face. So 11 for office visit, 21 for inpatient, 22 observations, and so forth. Okay, so this is different here. So modifier, Cigna is saying they will allow GQ, GT, or 95. So I read this and I read this over again just to make sure, and they're saying that you can use either 3 of them, any one of them from the 3. And it would all mean the same thing. But for reporting purposes, I think since all of them are saying 95, I think I would stick with 95 for all of them because it's just easier for us as coders. It's easier for the coder as well, and we're not making too many changes. So place service and the 95 modifier is pretty much across the board. So we'll keep it at that. That would be, and if you are comfortable using because you just like GT, to you. So non-COVID related visits, members must share apply. So that's new. Okay, so Cigna is not waiving this cost share. They're saying patients have to pay. So I'm not sure if they're going to change this, but as of April 9th, they're saying that anything that's non-COVID related, member cost share does apply. So if you're seeing a Cigna patient over telemedicine and they have, co-insurance and copay, then do collect that from the patient. Audio, video, or both are allowed. They're saying the same thing. Audio, video, both are allowed. And I'm not going to keep repeating myself. You guys already know what my stance is on that. G2012 patient cost share is waived. G2012 is that brief telephone call that pays about $13. So they're waiving the cost share for that. I wonder why they wouldn't do that for other telemedicine visits, but they make their own rules. They're also, so this is something interesting. They are also saying that they are going to be closely monitoring the use of level 4 and level 5 service, because Cigna is saying that, even though telehealth is there, telemedicine is available, we are going to scrutinize your level 4 and level 5 service, because there's the exam element is something that companies are saying is not does not factor into your level of service, because you can't really touch the patient, you can't really take their vitals and any of that. So even though you should document stuff, you should document everything. That what does the patient appear to you, how does the patient appear to you. So but they're saying that they are closely going to be monitoring level 4 and level 5 service. So I would definitely pay attention to that. And of course, they're also telehealth is available for new or existing patients. And there also a link over there on the bottom that has all the resources that are available from Cigna. So for prior authorizations, they're saying that any elective outpatient surgeries that were scheduled between January 1st and March 24th will be assessed when the claim is received and will go payable as long as it's within 6 months of the original authorization. So Blue Cross said you have to do it before December 31st. Cigna saying they would extend it to about 6 months. So if they gave you an approval, I don't know, February 1st, then I guess it's applicable until August 1st. So 6 months. Cigna will allow direct transfer to SNFs, acute rehabilitation facilities, and long-term care hospitals without prior authorization. So a lot of these insurances are pretty much saying the same thing, that they will allow it without prior authorization, but they still want to be notified. They want to be notified the next day. The receiving facility needs to notify them the next business day that they have this patient. Coverage reviews for appropriate levels of care and medical necessity still apply. So medical necessity will still apply. They're still going to be looking at stuff. They're still going to be reviewing these documents. So don't be surprised if they do ask for you to submit documentations. Don't be like, nope, but we were told on a webinar that everything is not waived. You still got to take it on a case-by-case basis. So last one I have, Cigna does not require 3 days of inpatient care prior to transfer to SNF. I think Medicare is doing that as well. So a lot of these insurances are kind of following in that step. Okay. All right, moving on to Aetna, and I promise this is the short one, and then we'll have Humana, and then we'll be done. Okay. So telemedicine policy updated April 15th. So literally yesterday when I was looking at this, they had just updated it yesterday. Aetna will waive member cost sharing for any covered telemedicine visit, regardless of diagnosis, until June 4th. Again, another date that's different. So all these dates are so different. I think we should just make a spreadsheet and put these dates in there. And I don't know, whatever works for you guys. But I'm really thinking that these people should just talk to each other and come up with something to make our life easy. In-network providers only. That's pretty much across the board for telemedicine, that they're only doing in-network providers. Aetna is also saying GT or 95 modifier is okay. So I was looking at the definition, and it's pretty much the same definition. synchronous telemedicine service rendered in real-time interactive audio and video telecommunication system. So both of these modifiers, their definitions are same. Synchronous meaning, it's real-time and it's two-way. Office codes that are eligible, 99201 to 99205 for new patients, 99211 to 99215 for established patients. And notice that Aetna does cover consult codes. So Aetna has the consult codes in their telemedicine directory that they will cover that. So if you are a specialist and you're seeing a patient that's referred to you by another physician, you can bill 99241 to 99245, granted that you have that referring physician's name on the claim. So if you don't have the referring physician's name on the claim, you cannot bill the 99241. A lot of practice management billing systems will give you an error message and won't even let you submit a claim with that if you don't have a referring physician in there. Cigna and United Healthcare do not recognize consult codes. United Healthcare did away with it in June of last year, and then Cigna did it in October, I believe, October 1st. Cigna got rid of them too. So, but Aetna is still allowing it. So that's good. And these codes actually pay more than your new patient codes. So if you have a referring physician that's sending you patients for consultation, if it's allowed, use it. You'll get paid more. They're also allowing G2010 and G2012 are also payable. These are those brief telephone calls. G2012 is the telephone call, and then G2010 is the provider reviewing reports that the patient has sent over digitally. Telephone visits are there, behavioral health services are there, inpatient hospital, and so Aetna did not have their list of codes available online, but they do have them available through Availity or Navinet. So if you are a provider's office, most likely you have registered for either of these portals for your eligibility checks and claims and stuff. So either Availity or Navinet, if you go on them, they will have this file that will have a list of all the codes, and including behavioral health codes as well. Okay. So prior authorization, temporary changes, updated April 14, 2020. So I want to stress this, temporary changes. So for every one of these insurance commercial payers that I was talking about, everything is temporary, guys. Nothing is in place and it's going to be there forever. It's all temporary. So do pay attention to end dates for sure. And that's very, very important that you do pay attention to when these dates are going to end. And it's not like they're going to give you a ring or whatever that, hey, we've changed it. You're going to have to go on their site and actually look for it. And we will try our best to get that information to you as it gets updated. But please also do your due diligence as well. So initial pre-certification, prior authorization for admission, post-acute care. This is pretty much the same thing that we talked about for all the others as well. They're saying that post-acute care facilities will be required to notify Aetna of the admission within 48 hours. So some are saying the next business day, some are saying 48 hours. So I would just do it the next day, not wait for 48 hours, because if you wait 48 hours for one that's only saying next day, that may be a problem. So let's just, keep things easy for us, right? Our job is to just make things easy and streamline the process, even though these insurance companies do their best to sabotage that. So pre-certification for elective procedures, they will review the requests, but they are saying that all healthcare providers are responsible to comply with the government directive to prohibit elective procedures during the pandemic. So this is going to be a case-by-case basis. They're not saying that we will extend it to a certain time. They're not saying any of that. They're just saying that, right now you should not be doing any elective surgeries because most governors have put a ban on that. So, but they will review the request. If you already have a prior authorization in place, then you can definitely call them and let them review it when everything opens back up and gets back to normal. Okay. And our last one for today is Humana. Humana policy. This was effective March 23rd, 2020. Audio, video, and audio only qualify as telehealth visits. Again, audio only, it's open to interpretation. I'm not going to say one way or the other. Waiving cost sharing for in-network providers. Place of service 11 for office visit, modifier 95. So like I said, some payers are saying you can use GT modifiers. Some payers are saying you can't. But everybody, if you notice, since United Healthcare, since the beginning of this webinar that we've talked about all the payers, everyone is saying 95. So I would probably just say 95, just to kind of streamline this process. E-visits, virtual check-ins, telephone services are all allowed. Of course, you need to check member benefits and verify. This is all plan-based. And then consult codes are allowed. So 99241 to 99245. Humana also allows consult codes. But of course, you know, the prerequisite is that you need to have a referring physician's name on the claim for that to get paid. Some resources that are linked here for Humana as well that you can see. They have all the codes in there for you. The behavioral health codes, office codes, hospital codes. All the codes are all available on these links. There's some administrative changes that Humana has listed on their site, and they're saying that they will, effective April 1st, Humana will suspend all medical record requests for pre and post paid claim review purposes, and they will start paying the claim. So if there was a claim that you had that was stuck for review or needed to be, or they're requesting medical records, they're saying they're just going to suspend that request, and they're just going to start releasing those claims, and they're going to start paying for those claims. So that's great news, I think. Although medical record claim reviews are suspended, medical records may be requested retrospectively. Oh, sorry, I don't know what I did. Okay, retrospectively once the suspension is lifted. So, I mean, I don't know if you're off the hook, because if they're paying you and they're saying, okay, we're auditing this claim, go ahead and send us your medical records now. I don't know if they would, recoup your money or whatever. I'm not sure. But right now they're saying that they're not going to be requesting any medical records. So that's great. Suspension of pre-authorization requirements and referrals. Nearly all pre-authorization requirements. So they're saying they're anything and everything. So you probably still want to find out what procedure codes they're talking about, because I wouldn't put a blanket statement on any of these. So they're saying that it applies to both participating in-network and non-participating out-of-network providers when the member has a COVID-related diagnosis. So that's something that even United Healthcare is saying, that they would pay the providers, even out-of-network providers, if anything is COVID-related, if the diagnosis is COVID-related. Also, and then they're saying, please continue to submit notification as normal when Humana covered patients are admitted to the hospital, even when authorization is not required. So even if authorization is not required, they want to be notified. So next business day is a great rule of thumb there. Okay, so this is something that I have been asked by some of our clients, and some stuff that I've seen out there, and I just wanted to address it, since we're talking about this stuff as to what's covered and what's not covered. So telemedicine well visits are not covered under commercial plans, and I did some research into this because one of our clients asked us to look into it, and nowhere did I see the well visit codes in there, and I think that's probably a good thing, because for a well visit you have to have, first of all, no diagnosis, nothing wrong with you, it's a well visit, and then the patient needs to be touched and examined and all of that. Examination is a huge part of a well visit, right? So none of them are covering it, but you're welcome to call and verify based on your patient population, but I did not see anything like that in any of these insurance payers. Incidental and shared services are not covered via telehealth, and I cannot stress this enough. I know that a lot of the doctors who have nurse practitioners and PAs working under them, they want to build these telehealth services under their tax ID, even though the nurse practitioner provided the service. That's not allowed, guys. Don't do that. I know you want your 20%, higher reimbursement, but let's do this the right way. Incident to, as everybody knows, I hope you know that incident to service is when a physician has established a relationship with the patient, established a care plan, and the nurse practitioner is actually following up with the patient, and there's no new diagnosis or anything. They're just kind of managing the patient's current condition. That can be billed as incident to. The provider has to be in the office suite and easily available. They don't necessarily have to be in the room, but that's what the criteria for incident to is. And shared service is for hospital only. Is if a nurse practitioner, let's say, sees the patient in the morning and the physician goes and sees the patient in the evening of the same day, it can be billed under the physician's tax ID or NPI. Because the patient was seen by the physician on the same day. That can be shared visit, but this is not applicable via telehealth. And so I was addressing some questions from some of our clients here as well. Audio only requirements must be clarified with the payer, and I stress this, all over this webinar. I told you guys about this all over this webinar, that make sure that you guys are clearly, asking about this audio visit billed as a office visit. Until now, Medicare does not allow that. So like I said, it says on the next line, Medicare still maintains the use of audio and video technology as telehealth. So for telehealth visits, if you're billing in office code, it is still required to be audio and video. Keep checking payer sites every few days for new updates. Like I said, things are changing on a dime. Last month, March 26th, when I did the first webinar on this, everybody was saying place of service was 02, but now everybody's saying place of service is wherever the patient is. And so things are changing, and we're going to try our best to keep you guys updated as much as we can. So look out for another webinar coming soon. I would probably say that we would probably do one on next Thursday, and that's going to be related directly to COVID-related diagnosis, testing, and other services. So we're going to share with you all the different diagnoses, the treatment plans, and the new antibody CPT codes, and any other services that are directly related to COVID-19. It's going to be a heavily coding-based webinar. For me, I give you all this information on regulations and guidelines and stuff, but the next webinar that we have is going to be heavily related to coding. So look out for that for sure in your email. This slide I've had consistently in all my webinars, that it's constantly evolving situation. New information's coming out daily. Stay connected and updated. Follow official CMS and payer sites, and also connect with us. We have a Facebook page, CodeRight Healthcare Consulting. Like our Facebook page. You can connect with me on LinkedIn. I put all my updates on our webinars, and whatever is happening on my LinkedIn page, we put it on our Facebook page as well. And we have a YouTube channel. So the past 2 webinars have been uploaded on our YouTube channel. This one will go on it, if not today, then possibly tomorrow or over the weekend latest. And we have a lot of other videos on there for practice management, for compliance, for billing, for revenue cycles. So we have a lot of that, all of that information in there on our YouTube pages, and more content will come very, very soon. So as of now, just I don't have anything else to say, but I will take questions if there are any questions. Let me see if there's anybody asking any questions. Okay, let me see. Are you